Hey, all right, everyone. Well, thank you so much for joining. I know that we'll probably have people continue to stream in here over the next couple of minutes, but great. Yeah. All right. Well, welcome to our department grand rounds, everyone. I'm really excited for this presentation. I think it'll be some great learning for us. And I will go ahead and start with introductions. So have the privilege today of introducing our guest speaker, Dr. Alexis Ritvo. So Dr. Ritvo is an MD and has her MPH and is a board-certified addiction psychiatrist. She is the program director for the Addiction Psychiatry Fellowship at the University of Colorado School of Medicine, where she is an assistant professor of psychiatry. And her growing interest in the safe prescribing and deprescribing of prescription benzodiazepines led her to become the medical director for the national nonprofit, the Alliance for Benzodiazepines Best Practices, in 2022. She is the current chair of the education committee for the American Association of Addiction Psychiatry. And with that, I'll hand it over to Dr. Ritvo.
Yeah.
Thank you so much for
Well,
being
thank you all for having me, and wish I could be there, but feel like you guys are about as close by as you can get as an academic partner. So I'm going to start by, well, first seeing, there we go. Why my slides don't want to go for it. So the reason I don't have my name on the title is this is actually back in December, I gave this as a grand rounds with these wonderful residents. And because these slides were created by all of us, even though they won't be able to be here to present their cases, want to make sure that they get credit for all of the great work they're doing. These are 3 residents, 2 that are 3rd years and 1 that's current 4th year that I supervise in our outpatient psychiatry clinic here at the university. And so disclosures, while it's not considered necessarily a eligible disclosure, I do disclose that I'm contracted as the medical director for the national nonprofit Alliance for Benzodiazepine Best Practices. So I have a contract with them that makes it part of my time. This is actually just a disclosure I was required to add because in our department, the psychologist can also get CME or CE. So the main point is, while I'm presenting clinical cases, of course, you still have to use your own judgment when seeing your own patients and not just directly apply anything I tell you directly to the patients you see. Learning objectives will review the pharmacology of benzodiazepines with a focus on the mechanism for developing tolerance and the risk of acute and protracted withdrawal. Evaluate some of the different approaches to outpatient benzodiazepine tapering and the associated risks and benefits of the different approaches. And we'll utilize cases to demonstrate how to approach challenges in benzodiazepine tapering discontinuation. As I told Dr. Sauer, I have a lot of material. I know I may not get through all of it. I do want to leave time for questions, and I will gladly share my slides so that you guys can look at them and feel free to outreach me with questions. So pharmacology. As a reminder, I know most of us will just think, oh, benzos work on GABA. So they enhance the neurotransmitter GABA at the GABA A receptor, which is also often referred to as the benzodiazepine receptor. And this is an ionotropic receptor and ligand-gated ion channel. So what does this mean? As the little picture shows from the 2-minute neuroscience video, is that benzodiazepines are not binding at the exact same site as GABA, but actually on a different site on GABA, near GABA, and they actually help pull GABA to its own receptor to increase the amount of chloride that is then pulled through this ion channel, and thereby increasing the inhibition in the nervous system. This is known as an allosteric effect, right? So it's not directly binding at GABA or in place of GABA, but it is actually increasing the amount of GABA. So what happens with chronic administration? As we know, our systems like to achieve some sort of balance or homeostasis. So anytime we increase significantly the amount of inhibition that we put on our system, there are all sorts of compensations that go on to try to then increase the amount of excitation in the system. So we have a decrease overall in the amount of endogenous GABA that is around. So if the system is feeling flooded with GABA and feeling like, whoa, I'm like way too inhibited, I need to make sure that the brain body is up, awake, alert, functioning, thinking. We have a decrease in endogenous GABA. We have a downregulation of the GABA A receptors and overall decrease in inhibitory impulses. Simultaneously, you get an increase in these excitatory neurotransmitters, so increase in endogenous glutamate, increase in endogenous norepinephrine and serotonin, so that underneath the system's pretty revved up. The way I often to explain it to patients, similarly when I'm explaining what happens when you have chronic alcohol exposure, is that if we too quickly take away this chronic inhibition on the system's revved up so much underneath that we get withdrawal because you get, anxious, sweaty, all these excitatory responses. And of course, if someone is significantly physically dependent, especially when taking higher doses, then they're at risk of even lethal outcomes like a withdrawal seizure. So how does tolerance develop? Tolerance defined as just the same amount of the drug or substance having less effect with repeated dosing. Tolerance varies based on the effect that you're looking at with benzodiazepines. For the sedative, hypnotic, or sleep effect, this can diminish within 1 to 2 weeks. For the anxiolytic effect, tolerance can show up after about 4 to 6 months. Again, it's going to vary by which benzodiazepine is being used and each individual's unique system and everything else that's going on in it and other exposures. The anticonvulsant effect diminishes over weeks to months, and yet there does not seem to be the same development of tolerance to the effects that benzodiazepines have on cognition and memory. So, the fact that people notice that their short-term memory may not be as good, that their cognition is slowed, does not tend to actually get better with time overall. I think there's probably some of it, but it's not something that totally goes away. Another thing that we think happens with tolerance, and they've looked and thought that they see this at some of the molecular level in animal models, is that there's some neuroadaptation that happens such that again, to try to keep this homeostasis, that you get this uncoupling of how effectively the benzo pulls GABA to the receptor, and it stops being as effective at doing that. And because of this decreased effectiveness, people start to find that the medication or the benzodiazepine they're taking is no longer as effective on their symptoms as they had previously been. And that may be because it's just not doing as good of a job as it used to, again, because our body's trying to compensate and actually decrease the amount of inhibition it's experiencing from chronic exposure. Another thing we should all know as prescribers of these medications, and will say actually very few, including even psychiatrists, seem to know this, is that in September 2020, the FDA updated their boxed warning. Now, they used to call them black box warning. Most of us still often refer to them as those. They just call them boxed warnings now. And part of that was not just, I think there's easily the focus on, these are medications with a risk of addiction or misuse or abuse. We know that they have a risk of physical dependence, but actually a focus on these withdrawal reactions that can occur, including both an acute withdrawal, but also a more protracted withdrawal that can occur. So I think this is a good thing to make sure we as prescribers are educated about, and also that we educate our patients, look, this is one of these risks that we should be making sure you know about when you take these medications, especially beyond 2 to 4 weeks. So common reports that came out in this theme or report themes that came out when they updated the boxed warning was that often benzodiazepine withdrawal was getting missed or misdiagnosed, and it was leading to increased doses of benzodiazepines. So, people weren't distinguishing, are you having increased anxiety because you're actually starting to have some withdrawal from this medication, as opposed to your anxiety is still significant and I need to increase the dose to adequately treat that. The other thing is that unfortunately, patients are often told, you're not on a very high dose, you can just stop that completely. Or they don't understand that they shouldn't stop this medication abruptly. And I've seen everything from just people having really bad, both acute and protracted withdrawal, to patients actually having withdrawal seizures because they suddenly were told, the Xanax you've been on for decades is not good for your brain, and they don't want to be on it, but they were not told, but do not stop it suddenly. So we have to be really cautious. So whenever I inherit a patient that is on these, and I'm sure you all are in a similar situation where we get referred a lot of these patients from the community, from primary care that have been on these medications long-term. And while we may want to work with them to get them on less, or if possible, completely off, we also need to make sure that we and they understand we can do great harm if we stop them abruptly or decrease them too quickly. So, they also reported that protracted withdrawal can last weeks up to 12 months. The truth is I've observed, and Heather Ashton, who maybe some of you have heard of, who is a psychiatrist in the UK who did a lot of work on benzodiazepines and kind of wrote the initial manual for tapering them, often referred to as the Ashton manual, observed that for some people, unfortunately, protracted withdrawal really can actually last in the order of years with some of the symptoms. Addiction and misuse of benzodiazepines are really not that common, and you see them most often among individuals that are misusing or have a use disorder to other substances. And so after this boxed warning, they recommended updating the warning labels, being more cautious prescribing, and that we made sure that patients are gradually tapered off these medications. So a big thing to keep in mind when we prescribe these medications and someone takes them on a regular basis, I would say that's at least daily or more, beyond 2 to 4 weeks, we should make sure they are tapered. Patients need to understand that we don't know, some people won't develop the physical dependence as quickly, others will develop it more quickly. Everyone's kind of unique and individual. But that 2 to 4 weeks really seems to be the pivotal period. We know the higher dose someone is using, the longer they're using it, as well as the more medical and psychiatric comorbidities and medications they're on, there's a greater chance that they will experience benzodiazepine withdrawal with trying to stop or cut back on these medications. And that we have to do this cautiously because, again, symptoms these medications were started for could get exacerbated or magnified in the setting of withdrawal, and also can become difficult to try to tease apart what's a withdrawal symptom versus what is worsening of the original anxiety or insomnia for which the medication might have been prescribed. While we think of the kind of typical heightened nervous system withdrawal symptoms, what we actually see is benzos act all over the nervous system and the body, really. And as a result, some people have withdrawal symptoms that seem less common, like I've now learned of benzo belly. So your gut is greatly affected by withdrawal, and some people get a really prolonged actual difficulty with their gut, feeling kind of bloated and uncomfortable, as well as really feeling nauseous and having difficulty tolerating much food. So as I mentioned, we know there's these acute risks. We also know there's this protracted phase. If you look in the literature, 2 of the terms that have gotten thrown around, that actually one of my colleagues published on one, which is complex persistent benzodiazepine dependence. And that came out almost right around the same time that another group of us had come up with the name benzodiazepine-induced neurological dysfunction bind. But the idea is, they're kind of overlapping. It's just that you can have these protracted withdrawal states that present with a lot of symptoms. Complex persistent benzodiazepine dependence kind of focused on that some patients can start to look like you start to question if they have a use disorder because they've become so dysregulated and have so much difficulty when you try to cut back or stop their medication. But it's really just in the setting of how significant their dependence on these medications are, and that if you try to decrease them or stop them too quickly, they do very poorly. And some patients may not even tolerate really getting off these medications once they've been on them long term. And so that was an adaptation from what's called complex persistent opioid dependence, which is a term that came out as we looked at trying to taper patients off long-term opioids and trying to determine who had a use disorder and who just had a really significant complex dependence to the opioids. So acute withdrawal phase in benzodiazepines, is going to depend on the half-life of the benzodiazepine you're looking at. So for the shorter half-life, like alprazolam or lorazepam, maybe closer to a 2-day onset, and then a peak around 5 to 10 days, and then kind of a tail and improvement. A longer half-life like clonazepam is kind of moderate, about 24 hours. You get up to diazepam, which depends on age, but for some people, half-life starts to be, if you're 50 years old, the half-life of Valium is estimated to be 50. It's actually an hour for each year of life. I should put that on a slide. I haven't yet, but so that's why it hangs around so much. So you can imagine the onset of acute withdrawal is going to be much, much later the older folks get with diazepam. And the hope is that after acute withdrawal resolves, that people will have symptoms that return to no more and hopefully less than what they were originally put on this med for. However, again, if this withdrawal is kind of not adequately treated, or we don't do a lot to try to minimize how severe it is, we seem to set people up to be at greater risk for more of a protracted withdrawal. Estimates are that acute withdrawal will occur in 50 to 80% of people that have taken benzos more than 6 months. But these estimates are kind of all over the place, and that's really because if you start making a list of what do you count as acute withdrawal or not, and like one study, they decided they weren't going to count anxiety because, well, is that the withdrawal? Is it the anxiety that's underlying? I'm saying it was too hard to distinguish. But I would just say, there's a really, really significant risk people will experience withdrawal when they're taking these meds regularly, and that some will get protracted withdrawal. As far as protracted withdrawal, so this comes from Heather Ashton's work. What she kind of observed was things like anxiety and insomnia that would eventually kind of diminish, especially in the first 6 to 12 months. Depression also usually improving within a few months. I will say a lot of people, if they've been on a lot of benzodiazepine, you get them off, actually, understandably kind of like feel like their mood is lifted and they have more range of emotion because they don't have this chronic inhibition. Cognitive impairment overall seems to improve. But this is something that actually there is more literature on that definitely can kind of stick around longer. And it's unclear if some aspects of the cognitive impairment may be more permanent or just take longer to resolve. Other things like perceptual symptoms, so ringing in the ears, paresthesias, numbness, pain, gradually recede. But some of these really stick around. I know certainly ringing in the ears and then akathisia is probably one of the protracted symptoms that I've seen be the most severe and debilitating, and actually some of the ones most likely to really lead patients to have things like suicidal thoughts and even, unfortunately, sometimes die by suicide. Other motor symptoms like muscle pain, weakness, tension, tremors, shaking attacks, jerks, spasms in the eyelids, and then I already mentioned the GI symptoms. So again, most of them tend to, kind of peak and then improve over time. However, also individuals that experience this, I said, my observation is it reminds me a lot of what we've learned of long COVID is, there's some group of people that have some sort of increased predisposition to this. It's just that we don't know yet why or who exactly that is. And that while symptoms get better, other insults to their systems, like getting sick, having an illness, stressors, can bring the symptoms back. And this is referred to in the community of affected individuals experiencing windows and waves. So windows of improvement of your symptoms and then waves of worsening symptoms. I have one colleague I work with who I think is now 10 years off benzodiazepines and still has noticed, they had COVID and some of their urinary symptoms returned that they had struggled with pretty significantly during their taper. So as far as what protracted withdrawal looks like, I guess already beat myself to the punch, but our best estimate is that it's about 10 to 15% of individuals, and that the symptoms decline but don't ever fully disappear for some of them. Again, it seems so individual, and like most things, we need more time and more funding and more people to participate. I think the most important thing is don't write off that this could be part of what's going on for a patient, especially if you hear a story of them attempting to cut back or get off of a benzodiazepine, or having trouble getting off, or having just a myriad of really kind of debilitating symptoms. Just because we don't have good research to say exactly how it works or what it's doing doesn't mean it doesn't exist. And so that's, what I've seen. And if you're kind of open to that, and even open to the idea that our other medications also have this risk of these protracted withdrawal states, you'll start to see that, it's present, and we should do as much as we can to more gradually reduce these medications. I'm not going to play this video, but this is actually an educational video. Someday I'd love to do a study where we send this to patients and kind of see who it helps encourage to try to taper, but also making sure that they want to taper more gradually. But this is kind of more of a layperson's explanation of how benzodiazepines work and how acute and protracted withdrawal occur. And it was made for a peer support curriculum that a group of us worked on for this group that's actually associated with our school of pharmacy called the Colorado Consortium for Prescription Drug Abuse Prevention. So how should we taper and deprescribe? So deprescribing is the planned and supervised process of dose reduction and stopping. A lot of the literature came out of geriatrics, where they're really strongly focused on trying to decrease polypharmacy and the overall risks of medications as folks get older, while trying to improve, maintain quality of life. So actually, I updated the words and I didn't update the title. So this week, actually, the first guideline came out. So American Society of Addiction Medicine published a guideline funded by the FDA on benzodiazepine tapering, or I think they're calling it tapering. There are no FDA-approved treatments for tapering or getting off these medications. And if I have time, I'll touch on what has a little evidence. Verdict's still out on how helpful. I think overall the guidelines will be helpful. We still have some concerns that people see guidelines, and what we saw happen with the opioid prescribing guidelines is that if they're too rigidly applied, there's a group of people that get hurt because the thought is, oh, we have to get you off these medications, and then it's kind of we don't leave room for the people where we might do greater harm than good, trying to force them off these medications if they're not able or willing to do so. So that would be my big thing is, read it, know it, follow it, but like all things, have some healthy skepticism that this is something new and is not like a one size fits all. Prior to that, we mostly had case reports, small open label pilot studies, anecdotal clinical experience, the Ashton manual, and then a few things like Cochrane reviews, systematic reviews, scoping reviews, looking at ways to taper. And overall, the quality of the evidence is low to very low. And that includes when you look at the evidence used for the ASAM guideline, it's actually not super high quality evidence that was used to inform it. Mostly it's clinical experience, like those of us that are working in here. ASAM, interestingly, did not, while they did collaborate with the American Psychiatric Association, I believe there's only one and maybe two psychiatrically trained physicians on the group that helped create the guidelines. So, and it was a very political process for how they reviewed and decided who got to sit on the guideline committee. So again, just healthy skepticism and knowing that we need more ways to systematically study this. We need randomized control trials about what are the best and the safest ways to taper these medications. I do not get any endorsement or money for this, but this textbook that came out of the UK, I find extremely useful. I keep a copy of it in our attending room that we frequently look at during staffing. So the Maudsley is kind of a well-known name in the UK for psychiatric textbooks, and they have their prescribing guideline textbook. And then last year they came out with the deprescribing guideline textbook. Mark Horowitz is a neuroscientist and psychiatrist who's done a lot of studies on deprescribing, both first antipsychotics and antidepressants. He hasn't yet published studies directly on benzodiazepines, although I believe he's working on one. And then put together this textbook, and it's very practical and helpful. I'm actually kind of use it as how I walk through some of these cases. So what the book actually has a lot of really good references. They're very good at referencing any kind of point they make, so you know where the information is coming from. So what we know, who's at highest risk for continuing a benzodiazepine? Those that are, as they get older, those taking more than one benzodiazepine or a Z drug, which also act on GABA A, taking opioids or gabapentinoids, so pregabalin or gabapentin, those that increase risk of falls, those with respiratory issues like COPD or respiratory disease, those with a history of a substance use disorder or a history of overdose, and those contemplating pregnancy or breastfeeding. Of course, that ends up being a vast majority of the patients that we're seeing that are on these medications and on them long term, because women are prescribed benzodiazepines even more frequently than men. So in 2018 to 2021, 5% of women and 3% of men received a prescription. Now, what this doesn't tell us is, were these intermittent scripts, was it really written? This is, someone has 10 tablets for a month, we don't know, as opposed to like someone clearly getting a chronic prescription. There's other data that does show that majority of people, when given a benzodiazepine, end up on a chronic benzodiazepine, and unfortunately, most likely as they get older. And that's what this shows. The elderly are prescribed more benzodiazepines than those that are below 65. I know this fits with what I see in clinic. Certainly if someone thinks that they're seeing something else, I'd be curious. And I know there's going to be regional variations and differences to the type of practices or places people are working. So when should we consider deprescribing someone that's been taking a benzodiazepine greater than a month, or as I said, maybe even as regularly as like daily or more for 2 to 4 weeks? They're older, when we start to feel like any adverse effects are leading to decreased function. Of course, if they have the risk of life-threatening interactions with medications like opioids, they've developed tolerance, they feel it's lost its effectiveness, based on the patient's preference, which actually should probably be the biggest box, and then to try to reduce polypharmacy. Benefits actually ultimately, when done cautiously, patients with time can feel like their anxiety is actually better controlled, can get improvement in psychomotor cognitive function, may reduce mortality that is associated with being on these meds, things like falls, lower the risk for motor vehicle accidents, and then decrease drug interactions. The risks of deprescribing. So is that experiencing withdrawal upon discontinuation. Again, you'll see these numbers kind of range, and it's just because it's the imperfect nature of how differently the studies are done. But one study said 15 to 44% of chronic users will experience moderate to severe withdrawal upon discontinuation. We know that people are at risk for protracted withdrawal, and so that's another concern. Factors that may increase difficulty withdrawal. There is a thought that with benzos, or the observation that with benzos, similar to what we see with alcohol withdrawal, there's this risk of kindling. And actually, probably this is something that can happen with all of our centrally acting or medications, that each time you experience withdrawal and it's not managed, the next time it will happen sooner and more severe. And so this is a reason to try to be more gradual in how we approach it, because if the system gets too disruptive, then it's kind of more sensitive to future disruptions. And then, of course, we worry about bad outcomes like suicidality, leading to death by suicide, akathisia, and other long-term disability. I will say the Dodds study in particular, while it did show increased suicidality, I know there's concerns about the overall methods that were used. But I will say, I think that's a big enough concern and something I've seen that's still worth noting. And all of the above things, we seem to be able to greatly mitigate by just adjusting how we taper, by going more slowly, by pausing, and then if absolutely needed, if symptoms are too severe, stepping back up to the previous dose. So before we taper, we should make sure we educate our patients about the tapering process, assess what their current coping skills are, how we could enhance their current coping skills. If we know they've been taking this medication for anxiety or for insomnia, how do we make sure that we're going to address those issues should we're expecting that they may arise as we taper? What contingency plans can we have to help them deal with the withdrawal effects, and or in this case, relapse could be return of the symptoms and or needing to return to the medication. What additional support can be provided? Do we have mindfulness skills we can give them? Insomnia management, certainly cognitive behavioral therapy for insomnia, also for anxiety can be helpful, or whatever kind of format. So knowing what your resources are, both within your clinics, within your community, as well as thinking outside the box for things like, if a patient has the ability, what would it look like to get them connected with virtual resources? Can they do an app or an online module, and would that help them, and could you check in with them about it? And then we're going to kind of try to guess what their likely risk of withdrawal effects are, and decide how to taper, or what initial taper approach to take based on that risk, and how we're going to taper it. So the way to think about it, this has a lot going on, but what you can simply say is the reason you want to do a gradual taper. So in the top example, if we do a huge decrease, we are forcing our patient's nervous system to go from one homeostasis, so the solid line, to create a new homeostasis that is a big gap, a big jump that their body and brain has to adjust to. If we do slightly smaller ones, which is B, we're decreasing the amount of change that their system has to go through. And if we make even smaller decreases, we are again making that change in homeostasis and the risk of withdrawal symptoms smaller. So kind of makes what I always say is like, we should always try to be kinder to our brains and bodies and go for kind of a smaller amount when at all possible. Hyperbolic tapering, the other idea to keep in mind is, right, going down by 2 milligrams when you're on 20 is not the same as going down by 2 milligrams when you're on 5. And the other thing that, what I really like about this textbook is they actually got together, the Maudsley textbook, information about the actual receptor occupancy and how it changes for different medication doses. And it's the same actually for antidepressants. They look at the serotonin receptor occupancy, because I think it's easy for us to just think in even percentages. And what you can see is that, going down by 5 milligrams is not going to be the same drop in receptor occupancy. So the term they use is called hyperbolic tapering, and that's the idea that as you get to smaller doses, you're actually going to have to make smaller decreases to try to keep about the same drop in receptor occupancy, and therefore try to minimize or decrease the amount of withdrawal. So that's what this graph is showing. So this is just an example of one, the table. So this is for Valium. So if you look at diazepam, if you look at diazepam, and you see that at 45.9 milligrams, you have 65% of your receptors occupied. You jump down to 37, you go down by 5%. However, you get down to 2.7 milligrams, right? And it is now just another 1.3 milligram decrease to decrease 5% occupancy. So it's actually, right, thinking in milligrams and percentages of milligrams is actually not all that helpful. It was the best we could do. We used to say, try not to decrease by more than 5 to 10% of the total most recent dose. But I actually increasingly like looking at these tables because I'm like, oh, this actually makes a lot more sense about what's actually going on in the brain. So what are we going to do before we taper? First, stabilize the daily dose of benzodiazepine. So, unfortunately, as our patients get more distressed and are having trouble, they tend to take their meds all over the place. This is one place where, unless your patient truly has only been using 10 tablets a month, then you're not going to taper it the same way. But if they're taking this every day, but it's variable what they're taking every day, try to get it so that they're taking a consistent amount every day. And then the schedule of how they're taking it is consistent. We are trying to minimize that they are causing different varying withdrawal day to day. Assess if you think they might have withdrawal between their doses. So certainly for short acting like lorazepam and alprazolam, I'll definitely try to make sure they're taking that at least 3 times a day, sometimes even 4. Anxiety, could be a sign of withdrawal, could just be they're used to it, getting rid of their, or decreasing their anxiety. And the anxiolytic effect of these medications tends to be even shorter lived than the withdrawal suppression. So again, you may need to do 3 to 4 times a day. For clonazepam, I often think of like twice a day as a minimum, sometimes up to 3 times a day. Even for diazepam, while I know the withdrawal should be suppressed if I'm giving it twice a day, because people are made uncomfortable by the anxiety, I will sometimes have them take it 3 times a day, or if I'm starting to switch from a shorter acting. Overall, you also probably want to try to convert and consolidate to one benzodiazepine if they do come to you on more than one. And so you'll usually then convert and try to get them onto whichever the longer acting that they're already on. And if they're still, despite stabilizing, their dosing and how they're taking it, experiencing significant withdrawal between doses or struggling with withdrawal when you decrease the dose, then I would actually do this crossover to a long acting. So switching from short to long acting, especially, so diazepam is really the one that is recommended. Clonazepam is not as long acting as we think, and it's also very potent. So I tend not to switch to that unless someone really won't tolerate diazepam, or they've been on clonazepam before and know they do okay with it, but it's really just not as long acting. I'll show you the table. And then again, dose, think about, clinical effect and how frequently you might dose. And I think the big thing is this bottom one. So some patients might not withdraw. You might not be able to get them off completely. And then you might just be working to get them on a lower dose that is at least safer. And I'll repeat that to my patients a lot because the ones, once they really commit to this, can get really beat themselves up that they feel like they should be able to get completely off. And instead I'll say, your brain and body's been used to being on this for decades. Like, it makes sense to me that we may not be able to get you to a place where you're stable if we take you completely off, but let's just look at like different goalposts of how we can get you on less and what improvements we can make. So this looks at the overall half-lives of the different meds. So as I mentioned, diazepam has this 24 to 48 hour half-life, but it varies really because of how it's hepatically metabolized. It varies a lot by age, and then it has an active metabolite. When you look in, I think it was Micromedics quotes one of those studies that just says you can estimate the half-life is going to be 20 hours at 20 years old and an hour for each year. And so that's how I kind of think of it, especially if I'm going to use it in folks as they get older. When I'm thinking about when is it going to reach steady state, is how old they are. That's the half-life in hours, although it's not accounting for the active metabolite. So clonazepam's, 20 to 60 hour half-life, but on average it's 30 hours. And these are equivalents across them. Sorry, real quick. So we think of, it varies by which sources you look at, but alprazolam, clonazepam are thought to usually be about equivalent. So I think of as 0.5 is equivalent to 10 of Valium and lorazepam 1. You'll see some variability. Clonazepam sometimes is thought to be more potent than alprazolam. All of this is clinical equivalent, so it does vary by individual. Available formulations, another thing I like from the textbook is it tells you, well, this is what it comes in the US. And therefore, what you have to work with. And then if you need to do something else, you may have to use a compounding pharmacy. So useful to know, clonazepam does come down to a 0.125 or 0.25 oral disintegrating tablet. Used to be harder to get and a little more expensive, and increasingly I found it more available. I've also used the liquid formulation. So that's, sorry, not for clonazepam, liquid for lorazepam and for diazepam. The UK has liquid, we do not. I have gotten it compounded. So what are we going to do? We're going to make an initial dose reduction. We're going to monitor their withdrawal symptoms. And then we're going to see, how do they do? What symptoms tend to be their most severe symptoms? How long does it take them to get better? And then do we make the same kind of percentage drop in this case, if I'm using the textbook kind of in GABA receptor occupancy, or do we need to go more gradual or less? I generally think about it that if I think someone's anywhere near the moderate to severe risk, if I have a way to make the smallest decrease possible, I'm going to do that to both get the patient's buy-in, make sure that they don't just happen to be someone that's more sensitive and going to have a bad experience, and then go from there. And sometimes then we do that, and I've had patients that are like, oh, it was really, I didn't notice much of anything, and then they actually speed up the taper. What I hate to have happen is you go with too big of a decrease, they have a bad experience, and then it's really hard to keep their buy-in that this is a process they should engage in and that is going to benefit them in the long run. And then you just keep repeating this cycle until you either get them off the medication or get to a dose that you feel like for now they're stabilized on. So here are the cases. I doubt I'll get to all of them in 10 minutes, but we'll see how I do, and then we'll make sure you have time for questions. So this was a case that came to one of the residents because she had been put on clonazepam 0.5 twice a day while on an inpatient psychiatric unit for increased anxiety in the setting of OCD. They increased the Prozac from 20 to 30 during that time. Then while the patient went to an IOP, the patient tapered themselves down to 0.25 in the morning and 0.5 at night of the clonazepam. came to us a few months later saying, I want to continue to taper because I know this has some risks in pregnancy and I'm hoping to get pregnant. And so we kind of talked to her about what the options were. She had overall said she'd done well with the decrease she made before, felt like her anxiety was adequately controlled, especially in the setting of both doing the IOP and being on the increased dose of the fluoxetine. And so overall assessed her as being kind of on the lower risk for more severe withdrawal outcomes. She hadn't been on the medication very long. She didn't say she had any interdose withdrawal between doses. Didn't feel she, had to keep upping her dose to get the same effect. So we didn't think she developed tolerance yet. She was on this, moderate to long half-life benzodiazepine, and didn't have a lot of other complications. So we said, okay, we'll keep making these decreases and monitor you kind of every 1 to 4 weeks. You can use the formal withdrawal scales if you want. What I tend to do is have patients pay attention to what do they think. And this is one of the things the textbook says too, like, are there kind of core symptoms for them of withdrawal that they notice? Is that anxiety, sleep, headache, restlessness, stomach upset, and when, keep track of when did those peak and then when did they decrease. And that will give us a sense of, in general, what their withdrawal looks like, knowing that we may have to slow or wait a little longer at certain points, or we may pause because they have certain life stressors or events or sickness or whatever that comes up. So this is just a graphic representation of, if you're asking your patient about their core symptoms, maybe they peak around day 10, that you could ask them, on a scale of 0 to 10, how severe was your anxiety or your headache, and then improve. And then around day 20, they seem to stabilize. So what we did, we still did, I guess it was following the faster taper, but I know I will say there's something about dealing with all these both fractions and decimals that can make your head hurt, and it makes me surprised that I ever somehow made it through calculus. But just check and double check your work, have patients double check, write it out. I mean, we write out these things. I write it out in the patient instructions. I write it out in the prescription. I write on the prescription when I'm writing 2 different doses, what they're to take it along with. And I often, the first time I do it, I call the pharmacy to let them know, hey, I'm prescribing 2 different doses of this medication because I'm tapering this patient. And that usually just goes a long way for them understanding that, why you're doing what you're doing. But this patient, they had a combination of 0.5 milligram tablets and the 0.125 oral disintegrating tablet, and those made up these doses. And if I recall correctly, actually, she ended up tapering herself even quicker because she felt like she was doing well and she was feeling very motivated. So this is what it looks like from the book. I'm sorry that font is so small, but it was following this kind of faster taper, which is a 5.2% decrease in the GABA occupancy. And they, again, this is not a exact every patient follows everything exactly. They say every 1 to 4 weeks. I tend to, with the first reduction, I usually give patients at least 4 weeks because I really want to see what it looks like for them, and then whether we're going to kind of what rate to continue at. I haven't had many patients that reduce every week, and especially with something like clonazepam or something like medium to longer acting, I usually want to see that it's reached steady state and they've had a little more time after steady state. So in her case, she had a high health literacy, so we gave her a copy of the chapter from Maudsley to say, here's our approach, here's the table of what we're following. I kind of base it patient by patient, whether I think it would be helpful for them versus overwhelming. And I've also had to modify how I do these tapers. I've had older patients where they're not going to be able to follow cutting a pill in tiny portions. And so then you have to get a little creative of what is reasonable, or can you enlist a family member that can create a pill box? Or is this where you do, use a compounding pharmacy? I've used some of the pharmacies make these pill packs. So where I may each month make a different dose and then have it. I think most of the ones I've used that do a pill pack, I think CVS does and then Amazon does, will at least cut the pills in half. I don't think they'll quarter them, but so you do have to get a little creative. But I've had a lot of ability to get patients, if not off, a lot less medication that's made it worth it. So another patient on alprazolam, very complex medical history with endometriosis and hypothyroidism, depression, anxiety, was put on alprazolam when they were also put on sertraline back in 2009. Had all back last January, started to have this increase in panic attacks, had long been on 0.75 twice a day. Although, right, doesn't sound like a super high amount, but remember, potency of alprazolam actually means that's equivalent to 15 twice a day of diazepam, roughly. So suddenly they add a 0.5 milligram dose. She's on 2 milligrams total daily of alprazolam, and within 2 months, it's like, I don't like the way this is making me feel. I'm not sure if it's actually helping me or making things worse. She starts to taper herself. Actually, before we even see her, has tapered herself down by half, but is having a lot of withdrawal symptoms. So, she's saying she's more anxious, she lost weight, she's nauseous, she's having these negative thoughts, difficulty concentrating. A lot of patients I've seen have reported kind of SI, or even kind of this passive SI, where they're like, this is not like me to have these kind of thoughts, but they're just there. But she really wanted to get off the medication. So we evaluated her as being kind of higher risk for more severe withdrawal, just because of how long she'd been on the medication and that she now had this difficulty with withdrawal. And decided that with her, that rather than continue to try to taper the alprazolam as it was, that we would slowly cross taper her to some Valium. And overall, we kind of said, okay, well, I'm trying to remember now, because I actually think we did maybe an initial dose reduction and she still was struggling with it. And said, well, we'll go ahead and cross taper you. So what it looks like was, this is the point I want to make. A big mistake I see people make when we think about putting someone on longer acting is saying, oh, so you're on alprazolam 0.5, that's equal to 10 of diazepam. Stop your alprazolam, start your diazepam. And then what happens? Alprazolam leaves their system. The diazepam has not yet built up in their system. They end up uncovered and have severe withdrawal symptoms in that time before. They think that, oh my gosh, my anxiety is getting totally worse. I can't tolerate this. If it's high doses, then they're at risk for really bad outcomes like withdrawal seizures. And so this is more complicated. You have to do a partial substitution. So you don't want to substitute the entire dose. You want to kind of go for half a dose at a time. I actually usually do half of a given time dose at a time. So they're on, 1 milligram in the morning. I'm going to substitute half of it for Valium and keep half of it, and do that over the course of a few weeks. Some people will say you can just go ahead and substitute the whole dose, like they're on twice a day. I just have seen it. People tolerate it better if we only go for half the dose. So in her case, switched her to Valium, and she said that her symptoms tend to be worse in the morning. So we thought she was having some withdrawal just in that time from the bedtime dose in the morning. So we started with switching her evening dose of diazepam. And so again, I know it starts looking super overwhelming, but again, like we do with everything, think like one step at a time. So you can see her evening dose, we substituted like for 2.5 of diazepam while keeping 0.25. And then we slowly did that, with each dose where we'd substitute part of it. Sometimes what you'll see, and I can't remember looking at this one, is if someone's tolerating really well, then I'll talk about what we could actually do while we make a substitution, equivalently decrease the dose a little bit. And that's one way you can kind of keep moving towards the taper. But it's something you kind of figure out as you work with these patients. So, and so this is, kind of thinking through the future as we get her all into diazepam, kind of what we'll likely continue to taper her doses with. Her going for a slower taper, so she'll eventually end up on the liquid diazepam, which I've actually, it's been pretty easy to get a hold of. So the last case, which I'll leave time for questions, so I'm not going to go through it, but is another one where this woman was on alprazolam. She was on it 4 times daily with and for 1.5 years and was just really having difficulty and was had gone to TMS treatment, didn't feel like it had been that helpful, and really felt like her alprazolam might be getting in the way. And why it was 4 times daily is because even though the half-life's 11 hours, the anxiolytic effect, is more like 2 to 4 hours, depending on the person. So she was motivated. We assessed her as kind of moderate risk. And so we slowly started, changing out these doses for some Valium. And she's overall done pretty well. So again, sorry to kind of rush through that. But that's where we are. So I'll get to the end here. Again, I'll share all this with you. There's some stuff about big thing, adjunctive medications. There's no convincing evidence to say, right, there's no reason these are gold standard. Things like carbamazepine and by extension oxcarbazepine have been studied, valproate, gabapentin, pregabalin. There's overall low quality evidence. The way I think of it is that overall there's a risk to this. The system's already perturbed, and we're going to give it, especially like another GABAergic med, that only, if it would be better to pause the taper or even go back up a little bit than to add another medication if we can avoid it. But I have had situations where, for instance, a patient had to be taken off their benzodiazepine really quickly because they could not safely take it because they also kept returning to alcohol use. And so I've used these to help kind of try to stabilize them after that. I have other colleagues that use them more. Again, it's just not well studied, so you're kind of going on theory and patient's experience. Some patients do want something else to try to help them feel better, and so kind of exploring whether you want to take that risk that it could make them feel better, could make them feel worse, or it may not do much. Okay. Questions. So someone said Ashton's been useful working with a compounding pharmacy to go down slowly. Agree with 5 to 10% lower dose. More problems I've seen. Insurance often doesn't cover the process. Yes, agree. The insurance piece, right? Like some of the people that probably need the most gradual approach are the ones that's going to be the hardest to do it gradually with, and then also get it covered. So I think knowing that clonazepam and lorazepam have a liquid solution. The Maudsley actually even describes how people can make their own suspension, although I get a little worried because I'm like, I think I'd have trouble trying to follow it. And someday I took chemistry. But just knowing it, yes, compounding pharmacies often aren't covered, but sometimes you'll see. So, and then, oh, hi, Dr. Bott. Dr. Bott also says when switching, include a note to the pharmacy stating you're switching, and the patient will be on 2 benzos to avoid chances of them not wanting to fill one. So yeah, I've found it goes a long way. I know it's one more thing to do, but calling and leaving a message for the pharmacist and making sure your contact info is on the script for the pharmacist. Any other questions, concerns, contentions, disagreements? I mean, I will say it's one of the more satisfying. I mean, I constantly repeat, this is a marathon and not a sprint to my patients. And when you're in the thick of it, I think you can feel also with the patients like, oh my God, are we ever going to get anywhere? But I can tell you, like, I can think I have one patient came to me on 3 milligrams of alprazolam, and he was older and having cognitive impairment and had some issues where we needed to get him on us, and we like slowly did some substitution. And now I have him on 4 milligrams of diazepam, and we're keeping it for the time being, but considering that he was equivalently on the that 60, 10, 20. Yeah, he was on 60 of Valium when he started. I'll take that. So you can really see improvements if you'll hang in there with people. So.
Snail here. Thank you, Dr. Ritvo, for a great presentation. No, I agree completely, right, with your approach. And I find, and I don't know if this has been your experience, but I find that in the field of addiction psychiatry, addiction medicine, there is definitely a group that really favors these rapid tapers, right? Using all those adjuncts, whether it's oxycarbazepine, whether it's pregabalin,
and all that.
Whether it's clonidine. And at least in my experience, I tend to have better outcomes. Maybe because so many of our patients have these underlying anxiety disorders, right? I just tend to have better outcomes with this kind of very patient, persistent approach. And I mean, I find we retain patients in treatment better that way. So
Yeah, I
yeah.
say, I mean, the only patients we do the rapid approach is when I truly reach my limit of I cannot safely continue to prescribe this. I'm
Mhm.
limiting that, you know, you're getting a week script at a time. And one patient where he was on monitored disulfiram, you know, we were limiting the number of scripts, and yet for the like second, or I don't know if we got to the third time, he, you know, was cheeking his disulfiram. He returned to alcohol use and took all the benzo at once. And so we made a decision very much involving him, trying not to shame him about it, but be like, your alcohol use is at the point where it just does not make this safe for us to continue this. And so here's what we're going to do. And he's someone actually, then we tried oxcarb. He got hyponatremic. Unfortunately, he thought it was helpful. We've used a clonidine patch and Depakote. And now he had, you know, he had to deal with some pretty uncomfortable protracted symptoms, but now he's really improved. We're actually presenting his case at ASAM, but he is kind of the exception that I would take. He's the reason where I was like, I feel like at this point it's less safe to try to continue this than doing a more rapid approach. So.
Thank you.
Good to see you. Well, thank you so much, everyone. It sounds like a lot of you are also doing this work, and keep it up. And I will, I think I already sent the slides to Christina, but if you don't have them, Christina, I'm happy to resend them and share them widely. So. Have a great Friday and rest of your week.